Well, hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, January 18th, 2026, and it is time for another IC support group meeting. Now, I will confess that I've been in a little bit of a funk today. I just did not sleep well last night. And then I made the mistake of reading a very sad book. So I'm trying to break myself out of this funk, and easier said than done. I also have a sore foot, so I can't go walk, darn it, which is what I would normally do. Now, my purpose in doing these meetings is to make you so strong, so knowledgeable, and so informed that nobody can mess with you again. I want to give you hope if you're newly diagnosed with IC. I want to give you structure. I want to give you valid and important information that will help you pick the right treatments for your unique case, that will help you work better with your doctor, that will stop you from wasting days, weeks, months, or years doing a therapy that does not have a bat chance in hell of helping you. IC today is very, very different than it was 30 years ago. We no longer consider IC a incurable bladder disease, rather as it is a pelvic pain syndrome for which there are many potential causes. And yes, there is a bladder subtype in there, but it turns out that 87% of patients who struggle with our symptoms of frequency, urgency, pressure, pain actually have very, very tight dysfunctional pelvic floor muscles, myself included. So, back in the old days, you were given the diet, you were given an antidepressant, God forbid you were given Elmeron, you went home, you were so happy to have a diagnosis, but the problem is you just didn't get better. You still had flares. I mean, surely if IC were a bladder disease, wouldn't bladder treatments help? And the answer is, well, for a lot of us, if not most of us, we actually have fairly normal bladders, that it's actually something else. I was working with a patient, I'll tell you, on Friday, and I often say this because I do patient coaching all the time. And here, hold on a sec. So we are live on Facebook and YouTube. Hello, gentleman with IC. He says, why God forbid Elmeron? Because it's now linked to patients going blind and losing their bowels. That literally they have to have their bowel removed because it can cause in some patients inflammatory bowel disease, excessive colon growth, polyp growth throughout the colon, some of which leading to dysplasia, which is a precursor to bowel cancer. And in fact, I was working with the patient, actually like 3 patients last week, 2 in one day. You guys, man, you worked me hard last week. I spent one day, I was on the phone for 6.5 hours with patients. Hi, Ann. And I think 3 of them were all patients who were having eye issues. You said, oh, great, I didn't take it very long. Thankfully, I'm really glad you didn't take it very long. Really, really important. And so username, listen, and I don't know what your name is. Obviously, your name on YouTube is username. Really want you to stick around if you can let me get through something, because we had a big conference and there was a big section on men. Okay. So guys, I've got a bunch of these things that I'm going to go over with you. I printed out 200 pages from a brand new conference on IC, and I want to share stuff with you, but I left a bunch on my kitchen table. Give me 30 seconds. I'll be right back. Okay. Alrighty. So this month, hello, Bonnie. Hi, Johanna. Nice to see you. Hope you're doing well. I started this meeting by saying, man, I've been in a funk all morning. I got a foot that's throbbing. It's always something, right? I mean, it's just like always something. So anyway, this month in the Journal of Neurourology and Urodynamics, which is published by the Society of Urodynamics and Female Urology, well, I will tell you, have excellent conferences that have covered IC. I've been to a couple of them. They finally released the articles from a very, very important meeting that happened last April at Wake Forest University. So one of the challenges that we have in the IC world is that, number one, as you well know, man, you could go to one doctor who says this, another doctor who says that, one doctor who says it's all in your head, another doctor who says it's incurable, another doctor who says it's not real. Obviously, there's tremendous diversity in perception and beliefs among urologists, depending upon how they were taught in medical school, and some are more compassionate, some aren't. It is what it is. And the reason why we have national guidelines is to give doctors a structure that they should follow when working with patients, from diagnosis to treatment, et cetera, et cetera. And so we have had national guidelines now since 2008 here in the United States. They've been updated 3 times. They were updated, they were updated in 2011, they were updated in 2014, and they were updated 2 years ago. So we have this fabulous set of guidelines that brings in a lot of different viewpoints. They bring in the best experts in the United States to create these guidelines, right? And they're important and they're good. They're really, really good. I mean, you can read them. I've got links to them on our website. They're where I go when I'm getting information, filled with attached research and all that sort of stuff. Now, if you consider around the world, you see tremendous differences in how doctors and researchers approach IC. And so in Europe, for example, they use a system that focuses on either 12 or 16 subgroups or phenotypes. And in Europe, every patient must have a hydrodistension with cystoscopy. In Japan, they don't use the name interstitial cystitis. They use the name hypersensitive bladder syndrome because they believe, and correctly, that for a lot of us, this is a nerve injury, nerve sensitivity, neuroinflammation disorder, right? And so there's a lot of diverse opinions out there, and it's like nobody's perfectly right and nobody's perfectly wrong. And our ability to work together, our ability to listen to each other, our ability to respect what other people have to say, most importantly, our ability to have a productive discussion is the foundation for the future, whether it be medical research, whether it be IC, whether it be politics. We just have to be able to talk to each other without, acrimony. So anyway, something absolutely amazing happened. Dr. Robert Evans and Wake Forest brought together 60 of the best IC researchers and clinicians around the world to the United States for what we call global consensus meeting. So in other words, where are we in 2025? What can we all agree on in 2025? And I had the chance to go. I was invited, but I was just dealing with recovering from surgery and all that sort of stuff. I really regret that I wasn't there because it was an absolutely dynamic, fantastic meeting. And I've got stacks and stacks of articles that I printed out because for some reason I didn't get my magazine this month. I wouldn't have had to do that if I got my magazine, but I did. So what I loved about this meeting is they took on head-on big, bold discussions about phenotyping. What have we all been talking about for the last 10 years now? the fact that there are distinct patient groups. We know that bladder therapies don't work for the great majority of patients out there. Why? Because there are underlying causation. And I started to say earlier with the patient that I was working with on Friday, man, I got to tell you, we went through this long history, and she had a tailbone injury and she had other things and estrogen atrophy, trying to figure out what her underlying phenotype is. And then she said something that blew it all out of the water. She said she had a massive fibroid tumor pushing on her bladder. And her doctor believed that the fibroid tumor was actually driving all of her increased frequency urgency. That's an example of a phenotype. She doesn't have a bladder disease. She's got a freaking, cantaloupe pushing down on her bladder that's making it difficult for her to urinate. Phenotyping. Be receptive to the fact that there are many potential underlying conditions that can be causing your urinary symptoms. Hi, Nancy. Hi, Bonnie. Bonnie says, we need more urologists who care enough to give proper care. Yeah, we do. But we're probably not going to use the name interstitial. We probably won't be using it in 10 years. I always tell patients that it's always better to go in and talk about your symptoms and talk about pelvic pain rather than interstitial cystitis, because you kind of fall down the well of poor training with respect to IC. A lot of doctors, when they hear IC, they just don't want to treat you. But if you say pelvic pain, you're good, right? Okay. So anyway, the global consensus meeting did phenotypes, and they had a huge debate, and their results are interesting. So here, hold on a sec. Let's see here. That's one. I want to get the right paper here. So just to refresh your memory, it was Dr. Chris Payne about 10 years ago who said, I think that there are 5 patient groups: Hunner's lesions, bladder wall driven without Hunner's lesions, like estrogen atrophy, pelvic floor, pudendal neuralgia, and of course, widespread pain, systemic pain, chronic overlapping pain conditions. We've used this system very, very successfully now. I mean, I use his system because I think it's really very, very good in helping patients understand potential causation. Then a couple of years after he came out, Curtis Nichol, who is one of the top premier IC researchers in the world, he was up at Queen's University in Canada. As he was facing his retirement, he decided to leave his recipes for treatment based upon his phenotypes or groups. He had 9. So, and in fact here, just to give you an example, let me go read those off real quick. And again, I'm happy to take any questions. I know I'm kind of flying through this, but you just got to let me get to where I need to go. Okay. Okay. So in the Curtis Nichol system, he believes that there's a Hunner's lesion group that he calls inflammatory IC. He believes that there's a pelvic floor group. He believes that there's a hypersensitivity widespread pain group. But here's where he became rebellious. He believes that there is an infection mediated group. And so he played the lead on the new UTI vaccines. It's called MV140. And of course, can you imagine how our lives would change if we actually had a vaccine that would prevent bladder infections? And so there are several different types of vaccines that have been explored. He's one of the key researchers. And anyway, in one of his studies, they gave the vaccine to IC patients, and about a half of the IC patients had their symptoms improve dramatically when they were given this vaccine, thus suggesting that perhaps infection was playing a little bit of a role. This is a small group, but it's a significant group. He also believes that there's an allergy group. And we've known that for years. It was Dr. Lowell Parsons who was the first to talk about how So many of his patients flared during allergy season or when they had the Santa Ana winds and pollens were everywhere. We know that IC patients can flare during allergy season. A lot of IC patients have a mast cell disorder. When, if you've got allergies or you have an overabundance of mast cells, those get triggered during allergy season. They release histamine that causes irritation and inflammation in the bladder. Curtis Nickel believed that there's a frequency urgency syndrome that he calls primary storage symptoms. He believes that there's a urethral pain group, there's a sexual pain group, and there's a flare group. Now, both Curtis Nickel and Chris Payne, they created the system really for clinical use. It's like, okay, I've seen 1,000 patients or more in my career. Here's how they present. And it's really about helping a young doctor not fall into the everybody needs a bladder treatment. It's about educating young doctors and giving young doctors tools to really look at your symptoms more carefully and come up with a wonderful individualized treatment plan. Okay. So anyway, so here we've got these phenotypes. Then, of course, these are doctors' opinions. They're based on research. But it's all about then waiting for an official organization like the American Urological Association or the National Institutes of Health MAP Research Network. I always want to hear what they have to say. Now, they are historically very, very, very conservative. They are very slow to change. We knew there were patient groups 20 years ago. I knew there were patient groups 20 years ago. We were talking about it as group leaders, but they want evidence. They want data. They want hard facts proving it. So in 2022, the American Urology Association, in their guidelines, hallelujah, they went, yes, there are phenotypes. What they did, though, is they combined a bunch in the same group. So, for example, they have their bladder wall group includes Hunner's lesions and estrogen atrophy and other bladder wall issues, which I happen to really disagree with, but that's what they did. And then they had their pelvic floor group, and then they had their widespread pain group. So, thankfully here now, we have doctors who are now being trained, and Dr. Henry Lai, who has taken the lead on this. He is now the new IC research director at University of Iowa, replacing Dr. Carl Kreter. He is the boss right now. He is so good at educating others about IC. And so when he teaches a class on IC at the AUA meetings, he's like all over phenotypes. Like, you got to understand not every patient is the same. Got to understand what these phenotypes are because they're going to help you treat these patients more correctly. Okay, so at this global consensus meeting, they were a little rebellious in a way. So what they did is they went through like 2,000 papers. They had a committee that started working on this months before the actual meeting, and they went through hundreds and hundreds of papers to try to ascertain what other researchers had developed. And they agree that, yes, there is a bladder wall group, and they too combined Hunner's lesions kind of sort of with the other things, but they're focusing on something other people really haven't addressed, and that is bladder capacity. That patients with a small bladder capacity, they believe, represent a very specific patient group as compared to patients with a large bladder capacity. So what they say is if a patient has a smaller bladder capacity, the odds are we're looking at a bladder wall dysfunction. If patients have a larger bladder capacity, that means that their bladder is probably pretty healthy and that it might be something else like their pelvic floor. Of course, the problem is that nobody agrees on what the exact number is, you know? And so is a low bladder capacity 100 cc's of urine, 200 cc's of urine, 500 cc's of urine, and they talk very specifically about how that's an obstacle. And AUA talked a little bit about bladder capacity too, but they bring all the science. They're really looking at biomarkers and all sorts of things like that, and inflammation and what a biopsy say about the bladder wall. They also believe that there is a systemic widespread pain phenotype. Okay, so now everybody agrees on that. That if you have pain beyond your bladder, not bladder centric, you might have bladder pain, but if you've got 3 or more spots on different parts of your body that also have pain syndromes, whether it's irritable bowel, whether it's vulvodynia, whether it's migraines, whether it's TMJ, whether it's fibromyalgia, you are in the widespread pain group, which is a systemic condition related to the central nervous system. So for you and me, because I'm in this group, bladder therapies will rarely work because it's not the bladder that is the underlying problem. It is this injured, sensitive nervous system, and we have to focus on nerves. So that's another way of sorting patients into groups. Does this patient have, and what they're doing now is they're giving you a body map at that first appointment, and you're supposed to show everything that hurts. Like for me, my left shoulder hurts, my left SI joint and sit bone hurt, my left toe hurts right now, you know, but I had a history of IBS and vulvodynia. So I'm definitely, and migraines and TMJ, although that's the right side. So I am definitely in this group. Also very important to understand that if you have a completely normal bladder, I mean, yeah, and so many patients are confused. You have a hydrodistension because you're peeing all night long and you're in a lot of pain, and that they look in your bladder and they find nothing. And then they give you that look of, maybe it's all in your head. It's not all in your head. It's all in your central nervous system. It's all in the nervous system. So we have to celebrate that. If you have a healthy bladder and hydrodistension, fantastic. That's great. What does that tell us? Then you probably don't need to do bladder therapies. We're going to move beyond. We got to look beyond the bladder to find the underlying cause. Okay. This consensus meeting also recognized pelvic floor dysfunction. No doubt about it. 87% of patients have tight muscles. And they talk very specifically about what we've been talking about for years, which is the chicken versus the egg dilemma. They were a little reluctant to let pelvic floor be its own phenotype because they felt that, you know, if you got a bladder wall issue and your bladder's in pain, your muscles are going to get tight to protect you from the pain. That's called the guarding response. Okay, but we now know that far more patients, the symptoms don't actually begin with the bladder. The symptoms begin after a pelvic trauma, like falling on your tailbone, having a baby, being assaulted, being an athlete. I was working with a patient this week who was what was she? She was a gymnast, and then she was a cheerleader doing flying splits. You want to talk pelvic trauma? That's a hell of a lot of pelvic trauma. I was also working with a gentleman this week who played football, and then he played baseball. And he has had every major joint in his body replaced, some twice. He has new shoulders, he's got new knees, he's got new hips, and he's dealing with a lot of IC issues. And yet, despite all of this, even though the doctor said your muscles are very tight, he never really understood why that was bad. I was the first person to explain to him why we have to work on that. That tight muscles create a very difficult legacy because they start squeezing blood supply and they start squeezing nerves. And I asked him, I said, okay, do you have sciatica? He goes, yeah. I went, okay. That tells me your muscles are so tight, they're squeezing your sciatic nerve. Have you considered physical therapy? He's like, no. And then he goes, yeah, my doctor mentioned it, but I just didn't do it. I didn't understand it. Okay, that's a specific group. He does not have a bladder disease going on. He absolutely has, no doubt about it, a really significant pelvic floor injury. So that is a phenotype. But here's where they got rebellious in a way. I wish I could have been in the room. I would have loved to have been there. Okay. They call it a variable phenotype. So in other words, it's where they're putting everybody else that they can't easily classify. That's an easy way to look at it. And in their proposal, they believe that, hold on. Number one, okay, the first thing they explored was, could this be microbiome related? Because hello, we've all been on a lot of antibiotics, and that absolutely destroys our biome and can create the growth of fungal infections and things like this. But in the research that they looked at, they didn't believe that there was any evidence that there was a biome difference, but I don't think they looked at Dr. Ann Ackerman's research, which found lactobacillus inners in some patients. Okay, so anyway, they're kind of throwing that out. But a promising area of research may be patients with recurring UTIs that coexist with their IC. A small secondary analysis of patients in a randomized controlled trial for the MV140 vaccine, a sublingual polybacterial whole cell-based vaccine developed for the prevention of UTI, both reduced UTI incidence among a subset of patients and provided relief for long-term IC in a small group of patients. Okay. So I think that that's pretty compelling. And remember, Curtis Nickel believes there's an infection-mediated IC2, again, small group. But his theory was a little bit different. He thought that the infection was gone, but patients had developed a hypersensitivity to the infection. Yeah, that's what he said here. Okay. Okay. They talk about many patients with IC have an extensive list of allergies, specifically medication allergies. Those with more than 3 allergies or sensitivities have more chronic overlapping pain conditions. And they have now been determined a multiple sensitivity phenotype, which is kind of what, I mean, again, Dr. Curtis Nickel was calling it an allergenic phenotype, but then he also had a sensitivity phenotype. So I really liked seeing that. They talked about using an anesthetic challenge to numb the bladder wall. And if that numbed the bladder wall, then that would confirm that this patient had a bladder wall issue as compared to a systemic issue. Oh, anyway, so let me just read their conclusion. Our review identified 4 key phenotypes: Hunner's lesion, low bladder capacity, widespread pain, and myofascial pelvic pain. 2 of these can be thought of as bladder-centric and are closely overlapping, those with Hunner's lesions and low bladder capacity. Both share mucosal inflammation at the level of the bladder and fewer systemic elements to their presentation. In other words, the patients are really just driven by bladder issues as compared to other issues. They are in many ways defined in opposition to the systemic grouping, of which widespread pain is the clear defining factor. Systemic patients also have more chronic overlapping pain conditions, the bladder-centric group. And those with myofascial pelvic pain appear to be the 4th separate phenotype. Additionally, those with multiple sensitivities, recurring UTIs, response to intravesical treatments, and painful bladder filling are promising areas of research to further define if they fully separate or fall under the umbrella of any of the 4 phenotypes we have put forth. It is important to recognize that while associations noted in this review support phenotyping patients, there are no hard binaries in IC. None of the studies examine each of these metrics simultaneously, and they do not define clear distinctions between patient groups. Anyway, yada, 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 yada. It is clear that IC is not just a syndrome of the bladder, but encompasses numerous symptoms. Effective research as well as clinical care relies on multidisciplinary teams as exemplified by, but not limited to, the MAP Research Network. Now, again, why is this important? Because this is how your doctor should be treating you now. Is we don't want to waste time doing a therapy that cannot help you. So for those of you who struggle with widespread pain, you've got the multiple pain conditions, you got the anxiety disorder, you got the sensitive skin, wicked sense of smell, all signs of a hypersensitive nervous system, your treatment priority has to be your nervous system, not your bladder. Don't get lost on just doing bladder therapies. They're not going to fix the underlying problem. Then the opposite is true. If you've got Hunner's lesions, what you're going to respond to are Hunner's lesion specific treatments. Now that's going to be a steroid injection into the center of the lesion. It might be fulguration or laser therapy. And of course, we now have lactoferrin, an over-the-counter supplement, which has been found to reduce some to reduce Hunner's lesions in a pretty big group of patients. So for these patients, doing a bladder installation going to be particularly helpful? Not really. Might be temporarily soothing, but it's not going to fix anything. And that's a challenge here. Like I was working with a patient who'd been on aloe for 20 years. A lot of aloe, a lot of aloe. And I asked her, I said, well, are you better? And she goes, well, my symptoms are controlled. And I went, okay, but your symptoms are only controlled when you take the aloe. So clearly the aloe isn't fixing anything. It's just covering up the symptom for you. So now we've got to figure out what's driving the symptom in the first place. We don't want to just chase the symptoms. We want to identify the underlying problem so that we can treat the underlying problem. And in her case, what was so interesting is she was terrified to have a hydrodistension or even a cystoscopy. And in all the years, she'd never had anybody look in her bladder. And she asked me what I thought she should do. And I said, well, we've got to follow the data here. Let's follow the data. What does the data tell us about your body? Number one, we know that you've got very, very tight pelvic floor muscles, which she did. She'd been in therapy extensively and they're really struggling. But she also had tremendous pain on bladder fill. And without letting a doctor look in her bladder, you are forcing the doctor to guess and you are guessing. You figure after 20 years of pain, don't you want to know what's going on? It's time. Listen, after 6 months of pain, it's time. You don't wait 20 years. If you've been in, like my personal philosophy is if I'm in pain, I want somebody to look at it and tell me what's wrong with it. Which means I'm probably going to have to go to the doctor this month, figure out why my left second toe is hurting like a you-know-what right now. It's also one knuckle is very red. So anyway, we don't want to guess. We need facts. And a clear fact in her case is chasing the symptoms with aloe in the end did nothing to fix the underlying problem. I think that she probably has Hunner's lesions that could be treated. So you deserve more than a guess. You need facts. You need to follow the evidence of what's happening in your body. Now, they also, another group at this conference did a deep dive into bladder biopsy results. And they were looking at, they were looking at the phenotypes and then looking at what the pathology shows in those patients. And so, for example, patients with Hunner's lesion have profound inflammation in their bladder wall. Their bladder wall is fighting something. And of course, now we have an idea of what that could be because they've now found virus in some patients, a viral infection in the bladder wall. But they've also found inflammation in patients with a low bladder capacity without Hunner's lesions. There's a whole thing on fibrosis. The authors theorized that immune cells degrade urothelial tissue in the bladder of Hunner's lesion patients, leading to inflammation and an eventual development of Hunner's lesions. So an autoimmune origin for some of these. The good news here also is they were able to firmly show that there's not a progressive worsening where like a patient with pelvic floor is going to end up with Hunner's lesions. They just didn't see anything like that at all. And that's true. They talk about how to treat Hunner's lesions. Patients with a smaller bladder capacity definitely struggled with more symptoms. Patients with a larger bladder capacity appeared to have more widespread pain, systemic issues, yada, yada, yada. Anyway, I've got all these notes here. In one study, only 28% of patients had bladder and pelvic pain, 75% had pain beyond the bladder, and 38% had 3 or more pain areas beside the bladder. Yeah, baby. This is good. This is all good stuff. There was a extensive discussion on treatment modalities. Where they basically ruled in and ruled out various treatments based upon phenotyping. We will be talking about all this in my magazine. There was a whole section on IC findings in men. Now, listen, there was a group on Facebook that used to kick men out because they said only women could get IC. Of course, that's completely wrong. So let me just go. The diagnosis of IC in men is fraught with difficulty as there is much overlap with other chronic pelvic pain syndromes, specifically chronic prostatitis. Key clinical features specific to IC are pain with bladder filling and relief with voiding. Painful ejaculation may be indicative of pelvic floor dysfunction. A physical exam, including extensive pelvic exam, to study the pelvic floor. It's critical in obtaining the correct diagnosis. They also want men to have an ultrasound with or without urodynamics to rule out an obstructive disease, benign prostate hyperplasia that might be making it difficult for you to urinate. Love seeing men getting their due. There's a lot of discussion here about epidemiology. How many men are there? Different studies have different things. Given these broad overlapping definitions, it is not surprising that IC in men is believed to be significantly undiagnosed and often misdiagnosed. In a recent study, it was shown that urological symptoms are more severe in men with IC compared to women with IC and men with chronic pain syndrome. The most prominent symptom of IC in men includes suprapubic pain, frequency, nighttime urination. The symptoms are aggravated when the bladder is full and alleviated with urination. These patients develop intense pain and or discomfort when asked to withhold urination rather than the urgency or fear of leakage described by men with bladder outlet obstruction. So in other words, if you've got benign prostate hyperplasia, the odds are you're going to have more incontinence than a typical IC patient. Many IC patients experience significant sleep disturbance, waking up from pain rather than full bladder sensation. In men, pain associated with IC has also been reported in the low back, perineum, scrotum, in addition to the suprapubic region. Pain is described as prickling or burning. Pain described as prickling or burning may signify a neuropathic origin of the pain. I hear something else. Pain with bladder filling. And pain perceived by the patient to be originating from the bladder is defining symptom of IC, whereas pain that commences with urination can be associated with an inflamed prostatic urethra. Painful ejaculation is less specific and is seen in both conditions. All right, hold on one sec. During a physical exam, suprapubic tenderness is common in men, along with anterior rectal tenderness and tenderness in the perineal body. Now, remember, we have talked about the perineal body. The perineal body is an attachment point for a bunch of muscles directly above the perineum. So the perineum is that bit of skin that goes from the vagina to the rectum or the scrotum to the rectum. And that little sucker can be a real hot potato of agonizing pain. For me, it felt like somebody was rubbing it with metal, like they were rubbing it off with sandpaper. And you go to the doctor and the doctor says, well, I don't see anything. Your skin looks great. And you're like, well, why does it hurt so bad? And you're thinking infection. No. It turns out directly underneath the skin of the perineum, it's the perineal body. It's an attachment point for 4 muscles. That's what's hurting. You got muscle stuff going on there. So here's what they say again. Suprapubic tenderness is common along with anterior rectal tenderness and tenderness in the perineal body. Tenderness in the prostate on digital rectal exam is not common in chronic prostatitis and is mainly associated with acute bacterial prostatitis. And then they want patients to map all their pain. All right, so there's more going on there. I will confess, guys, just, I've always considered myself a bit of a geek, right? I mean, I've got like a bunch of science degrees, so obviously I am a geek. My brain doesn't like to be much of a geek anymore. So my brain rebels when I start reading a lot of research. Men with pelvic floor overactivity may require extensive pelvic floor relaxation, physical therapy. All right. Now, for women, they did the same thing for women, my friends, right here. The role of gynecological findings in IC and bladder pain syndrome, a consensus. Now, I did not read this extensively. So let's just go through this. A number of associated gynecological disorders may overlap with IC. Our consensus committee identified 5 main disorders: endometriosis or adenomyosis. Number 2, genitopelvic pain penetration disorder, also known as sexual dysfunction. That means that trying to have sex or trying to stick a finger in there, trying to put a speculum in there, very, very difficult, provokes a lot of pain. Overactive pelvic floor muscles. Hormone-associated genitourinary changes, aka genitourinary syndrome of menopause, and vulvodynia, vestibulodynia. And what they say here is, while not exhaustive, this consensus highlights the most prevalent gynecologic comorbidities associated with current literature. Clinical evaluation should prioritize a detailed medical history and pelvic exam to identify any of these overlapping conditions. All right. So with the endometriosis is characterized by the presence of endometrial-like tissue outside of the uterus. It's considered a chronic estrogen-dependent inflammatory condition. Generally, would kind of, I think it should be its own phenotype, to be quite honest. Prospective studies have reported an overlap between the two conditions in approximately 65% of women with IC patients with endo tend to have a large bladder capacity, increased incidence of chronic fatigue, fibromyalgia, pelvic floor dysfunction, consistent with the systemic phenotype. Then they talk about vulvodynia. Among patients with IC, the prevalence of concurrent vulvodynia ranges from 25 to 85%. Embryologically, the urogenital sinus gives rise to the urethra, bladder, distal vagina, and vestibule, suggesting that a disorder of the urogenital sinus-derived epithelium could lead to concurrent pain in both the vagina and the bladder and the vulva. And then they talk about mast cells triggering histamine. All right, let's see here. They talk about tight pelvic floor muscles, vaginismus. They talk about patients whose muscles, pelvic floor muscles, are just not able to relax. Non-relaxing pelvic floor, fixed pelvic floor, pelvic floor tenderness, overactive pelvic floor muscles. This dysfunctional muscle engagement is typically involuntary, leading to an inability to relax the pelvic floor, which can cause difficulty with urination or defecation. We know this. And what do we always say when you go to physical therapy? The question that you ask your physical therapist is, are my muscles responding, or are they always locking back down into tension? If your muscles are always tight, we got to figure that out. Hi, KB. KB says, I've used Elmeron generic for decades and I have no impact on my eyesight. Congratulations, hon. I'm glad that that hasn't happened to you, but that's happening to it. At least our study of 2,000 patients, 54% report changes in their retina. Nancy says, can disc protrusion at L4, L5, and L5S1 cause bladder sensitivity? The answer is yes. Yes, it can. Okay, getting back to this consensus thing, they're actually talking also about the role of childhood trauma as being a risk factor for widespread pain. And we know that many young girls and older girls have been sexually hurt in ways. That's for my generation, what I'm 65. Virtually everybody I knew in high school, all my girlfriends suffered sexual attacks, myself included. Mine was at Choate Prep School one summer. The top tennis player in Canada decided to jump me at the time, one of the top players. Thankfully, I was rescued. All right. So I am summarizing all this research, or a lot of this research, in our Winter IC Optimist, which is like 95% written. I'm just doing the last part of it now. And what this should show you and give you comfort in knowing that there are people still studying IC, people around the world still studying IC. And good things are happening. Really good things are happening. And the fact that we can get together as a group and talk about best care practices for IC patients is just fabulous. Now, we all owe a debt of gratitude to Robert Evans, who has long been considered the best IC clinician in the United States, if not in the world. He's won Best Doctor every single time we've ever done it. Robert Evans has been out for about a year now with what appears to be a post-COVID blood clotting disorder. And so more and more of his patients, former patients, are calling, desperate to find new doctors. They do not appear to have a good transition plan for patients who used to see him. I haven't heard from him in a couple of months, but I'm pretty sure he's probably done. What he wanted me to tell you guys is that if he can come back, he will, because he loves his work and he loves caring for IC patients. His problem right now is that he's got blood clots in his arms and legs that make working impossible. He's in so much pain from them. And there was a very big worry that it was actually, apparently this happens with pancreatic cancer. And so they were very worried that perhaps he was getting pancreatic cancer, but all of his cancer tests had come back fine, which is now why they believe that it's related to COVID in some way. So anyway, here he is out, unable to walk, and he still manages to put together a fabulous research meeting on IC, he and his team. Wonderful, wonderful, wonderful. We owe them a tremendous debt of gratitude here. All right, let's go back to your questions. Hey, Jane. Jane on YouTube says, longtime follower, first time joining a live chat. Nice to see you, Jane. Very nice to see you. All right, let me go back. So remember, we're live streaming on both YouTube and Facebook. Last week, 5,000 people watched it, which was amazing. So let's go through this. Johanna says she's doing better, but then she got a flare. Hello, Nancy. Bonnie says, I was found to have a kidney stone on top of my IC. Yikes. And here's the thing about kidney stones, and I've gotten into pretty aggressive fights with certain people about this. Kidney stones are crystalline in nature, and they have lots of edges and sharp points. And so when you have a kidney stone that is released by the kidney, it's going down your ureter into your bladder and out, it's not like a smooth little pea going through. It is a sharp little sucker that is basically injuring and touching tissue. And that's one of the reasons why kidney stones can be so incredibly painful. But here's the other thing about a kidney stone, and this was from the American Urology Association, a meeting a couple of years ago, covered with bacteria. Just covered with bacteria. And so you think here you're basically injuring the bladder wall and at the same time introducing bacteria into the bladder. Yikes. So lots of very interesting research happening with kidney stones right now. Username on YouTube says, I bought the lactoferrin after I saw your video. I hope it helps. I hope that it helps you, honey. I really, really do. So we have here on Facebook, here, hold on, let me get down there. Somebody was saying, here we go. Linda says lactoferrin seems to be helping me. And we're getting quite a few patients who are calling and saying that they're sticking with it. They feel that they're better. They're not getting up as much. They're much more comfortable. They're able to drive without pain and discomfort. So the lactoferrin isn't for everybody, but it's certainly helping some patients. And I think worth a shot for 3 or 4 months, maybe 5 months. Paula says, I returned to see the specialist who saved my life after a year. His nurse was so happy to learn how they restored my life. First time I visited them, I was devastated and had little hope. My issues were related to estrogen and stopping energy drinks. Wonderful, honey. Oh, I'm so glad. So what that tells me is that you're the bladder wall phenotype driven by estrogen atrophy. So your bladder wall couldn't defend itself because you didn't have enough estrogen to make mucus. And then unfortunately, you were drinking like the single worst drink you can drink on an IC bladder, which is an energy drink. And so that profound acid and caffeine just irritating the hell out of your bladder and irritating the heck out of the nerves. So now that they've gotten your skin better and you stop the energy drinks, your bladder's good. So that's not a disease, honey. There's no disease happening with that. That's just a chemical injury from the energy drink combined with a dry, sensitive bladder. Loretta says, can bladder pain be caused by pudendal neuralgia? Well, we have something called, okay, so what is pudendal neuralgia? Pudendal neuralgia means, pudendal neuralgia is a structural problem, that the pudendal nerve is being compressed, irritated, injured by something, usually tight pelvic floor muscles. So another example of that, again, is sciatica. Sciatica, when you got that sharp pain that shoots down your leg, that's your pelvic floor muscle, that's your piriformis muscle squeezing the sciatic nerve. Other muscles can squeeze the pudendal nerve. And symptoms of pudendal neuralgia are going to be pain with sitting that gets better with standing. You might have something called PGAD, persistent genital arousal disorder, where you feel aroused at random strange times, and it's not a happy arousal. It's a painful arousal. Why is this happening right now while I'm working? That's a classic symptom of a muscle squeezing the pudendal nerve. You might have pinpricks, areas of numbness. For me, I have a pudendal neuralgia on the left side of my pelvis, and it manifests as a vibration sometimes like this, but that's also related to tight muscles. But pinpricks, getting little pinprick sensations down my vulva, front to back. That's also a symptom of a pudendal neuralgia. So your question is, can bladder pain be caused by pudendal neuralgia? Well, we have something called neural crosstalk. And what that means is that the nerves in the pelvis merge at the spinal cord. The nerves in the bladder, the nerves in the bowel, the other nerves, they all come back and merge around L4, L5. And as a consequence, inflammation in one area, in one nerve, is going to go up to the spine, and then that inflammation can spread to the others, and it's going to go back down to other parts. There's a condition called allodynia. Allodynia means that, okay, so like it happened to me in my second year with IC. When my IC started, and remember, I'm a pelvic floor nerve patient. It was never my bladder. But when I pushed in over my bladder, when I pushed in that area, it was uncomfortable. But what happened is it started getting comfortable higher up, and then it got uncomfortable by my belly button. Now my belly button is 6-7 inches away from the bladder, and yet my belly button got very, very tender to touch. That's called allodynia. That's where the proximal nerves, the nerves near the injury, are also now showing signs of sensitivity and irritation and potentially neuroinflammation. So, but is there a direct correlation? No. Loretta, what I would say instead is you've got to ask what drives both. Pudendal neuralgia is driven by tight pelvic floor muscles. Bladder pain can also be driven by tight pelvic floor muscles. So what I would want to know in your case is what's going on with your muscles. Dawn says, what about years of endometriosis and 7 female surgery? That's brutal, honey. It's brutal. Number one, you've got the physical injury from the surgeries. You probably have a lot of scar tissue from the injuries now. Plus, you've got neuroinflammation from the endometriosis and the widespread discomfort from the endo. The Endometriosis Association is absolutely fabulous. If there's a nonprofit you should join, it's that group. I interviewed the founder of it several years ago, and she blew my mind when they were talking about what causes endometriosis in the first place. And they had an amazing breakthrough early on because the IC movement and the endometriosis movement all got started in the 80s. But they had a big breakthrough early on. And that is some researchers published a paper showing that a man-made chemical, dioxin, caused endometriosis. And that's a whole nother story. Well, it's an animal research study that's absolutely heartbreaking. They were basically just testing. The plastic industry was trying to prove that burning plastic was safe. Burning plastic produces dioxin. So they were giving increasing levels of dioxin to monkeys. One of them died, and they did an autopsy, and they found it was filled with endo. And that was their first clue that endometriosis could be driven by what we call estrogen mimicking chemicals, man-made chemicals. And now every couple of years, there's a new chemical that's added to the list. So one of the things the Endometriosis Association tells us all to do, I think we all need to do it, is get rid of all the chemicals in your home, like no oven cleaners, no scented candles from China, no Febreze, no delayed plugins, nothing that's going to add a chemical scent to the air that you're breathing. And also removing chemicals from anything touching your body. That means going with a plant-based laundry detergent, no Febreze, nothing like that. We gotta bring the chemicals away. I mean, there's just too many things happening from all these chemical exposures, not the least of which is cancer. Okay, let me go back here to YouTube. Hello, C. Sterling. Been listening for many months now. Hunner's lesion controlling my life. Had the fulguration surgery twice. The last time followed a strict diet and all the recommendations. The lesions have returned. Okay, so yeah, number one, you're not alone. Lesions are known for returning. The goal is hopefully fewer come back. Okay? Sometimes they don't come back. Sometimes they can come back. And this gets down to what's driving them in the first place. Like what specifically is causing a lesion to grow. Now, there are kind of three theories on what's doing this. Theory number one is that it's an active viral infection. You know, when you have a viral infection like Epstein-Barr, mononucleosis, or HPV, or herpes, or polyoma, I mean, we all have viruses in our body and they just live very quietly along our nerves. And then when something happens, an injury or your health is affected in some way, the viruses turn on. And we have really good credible research, which has found the Epstein-Barr virus in the urine of patients, in some patients with Hunner's lesions. Okay. And so if your lesions are always coming back, no matter what they do, it would be, and we have all this information on our website, it would be very interesting to ask your doctor to do some blood tests to see if you've got antibodies for Epstein-Barr or active Epstein-Barr. Because if you do, then we're going to do perhaps some antiviral therapies like starting lysine, avoiding L-arginine, doing lysine instead because lysine interferes with viral replication. They might even put you on an antiviral. We've got some early research that has been testing that. And that's where lactoferrin really shines because lactoferrin boosts your immune system and helps your body fight off infections, bacterial, viral, and fungal infections. So theory number one is that it's a viral infection. Theory number two is that it might be autoimmune disease. There's an autoimmune issue going on. Now, I will say that in previous studies, when we've looked at, like, how many patients have Sjogren's or lupus or something like that, classic autoimmune disorder, very, very small, like 2%. But in this consensus meeting, they were talking very specifically about the theory that an autoimmune dysfunction can be occurring. And then, of course, the other thing we're going to look at is neuroinflammation, nerves that are very irritated, because an irritated nerve releases something called substance P, which damages tissue. So when you think about a shingles outbreak, when you got this awful red rash, very, very painful to touch, what's causing that red rash? Well, we've got nerves that are irritated, and they're releasing something called substance P, which damages tissue. Now, this neuroinflammation has actually also been linked to a damaged ligament, the uterosacral ligament. It turns out when the nerves are leaving your bladder and going up to the spinal cord, this nerve rests on a ligament that holds it in place structurally. And when that ligament is damaged, what happens to the nerve? The nerve goes, whoops. The nerve gets pulled out of place. We call this posterior fornix syndrome, and we now have patients. We have a published study of a patient who had severe Hunner's lesions, and she had a severe prolapse. And when they went in to repair her prolapse, they found that her ligament had broken, and her uterus was actually facing backwards. So when they repaired everything, got everything back where it's supposed to be, her Hunner's lesions completely disappeared. She's considered a complete and total cure. And the posterior fornix syndrome people believe that that's a phenotype for IC, and I agree with that. I think we need a lot of phenotypes. I'd like to see 20 or 30 phenotypes. Because think about the patient I talked about earlier. Her IC symptoms are being caused by a giant fibroid tumor pressing on her bladder. a really large one. And she just didn't want to have the surgery to have it removed. And she now really regrets that. Okay, so did she have a bladder disease? No. Jane said, I passed a 5-millimeter kidney stone a few years ago. It didn't affect your IC at all, thank goodness, but yours is pelvic floor driven. Yep. Username says, could my Hunner's lesions be caused by inflammation elsewhere in my body? No. No, Hunner's lesions are, no. It's inflammation in the bladder wall. The question is what's causing that inflammation. It could be a viral infection, it could be autoimmune disease, or it could be neuroinflammation. C. Sterling said, been taking lactoferrin for about 5 months, have not noticed a significant difference. I only drink water now and I'm very careful to avoid. Hey, listen, at least you gave it a shot. User says, so this could be viral? Definitely. Why would fulguration help temporarily? Because fulguration burns a nerve and breaks the nerve and turns the nerves off where the virus lives. But then the nerves always grow back. Oh my God, I want my Hunners to go away forever too. I would love that. I know. I mean, that's why and like, here's the thing. Oh, how do I want to say this? I want to, so I lifted something heavy, so my incisions are not happy with me right now. As great as it is that we've got doctors debating phenotyping and patient groups and all this sort of stuff, I think the ultimate opinion really should be ours, because they need to talk to us a lot more than they do. You're lucky to get 10 minutes with a doctor, then they do urine tests, they might do a hydrodistension, they might do a biopsy. They're making all those decisions based on that. They need to talk to us. I can remember my first year with my IC, with my beloved Dr. Mark Klein, who was my urologist at the time, long since retired. I said, Doc, here's the thing. My flares follow a very specific path. I start with perineal vulvar pain for a day, then I get urethral pain for a day, and then my bladder kicks in. Every single time, that's how my flares began. And now I recognize it actually begins with rectal pain, then perineal pain, then the bladder, etc. Anyway, I'm like, what is that? And he's like, I don't know. Jill, I have no idea. I'm like, and now we know what that is. Those are tight pelvic floor muscles that are just getting tighter and tighter and involving more things. My pelvic floor flares always begin now on the muscles around my rectum, my levators around my rectum. So we have, I can remember when a new system was proposed called UPoint, that was developed in Canada, by Curtis Nickel, saying, okay, you can't just look at the bladder. You got to look at widespread pain. You got to look at the muscles. You got to do this and you got to do this. Look at the totality of the patient. Don't just focus on the bladder. And I remember how elated we were that they were finally recognizing us as a person. They were finally respecting the fact that our entire body could be involved. So, and that's why it's so important that patient representatives go to these meetings. But the challenge is that a lot of the patient representatives go to the meetings, don't work with patients like I do. There's also kind of and again, I was invited. Okay, so I just couldn't go physically. But the point that I'm trying to make is that there are consistent patterns that we see that they may not see that could help us understand this. It's that simple. We are not objects to be studied. We have input. Our opinion matters. Our story matters. They need to listen to our story. And that, in the end, is what's going to advance phenotyping in the long run. which is, again, why I think I want a lot of phenotypes. I don't want 3. I don't want y'all to mush them up in one, 2, or 3 groups. We got to have the fibroid group. We got to have the hormone-driven group, patients who flare badly when they're ovulating. We have to have the injury group, because there are a lot of people with injury. We need to have a chronic prostatitis group, potentially for men, just to try to understand the connection there. There are some men who have pain at the tip of their penis. What's that? It's usually referred pelvic floor pain, but I mean, that's a group. And I just want more groups. I want more detail. I don't want less. I want more. But they want the science. They want to see the science that prove that that's a distinct group. And it's like, yeah, but listen to the patient. If a guy has pain at the tip of his penis for 20 years, that's real. And if every guy you work with, or 80% of the men you work with, have pain at the tip of their penis, then that's real. You might not understand why that happens, but we have to understand it, and we've got to treat it. I hope that makes sense. I'm pretty outspoken. Wilma says, what is done to treat the nervous system? Central nervous system therapies, like if you want to try a supplement first, that would be PEA 500 or P-Leaf, palmitoyl ethanolamide. Normally you would start with the supplement because they don't come with the side effects. If that doesn't work, then you can go to something like gabapentin, amitriptyline, usually gabapentin, maybe even a little bit of amitriptyline. But also we got to get your brain out of fight or flight, because that's when we have the Chronic Pain Research Alliance. It was studying widespread pain. Then they studied the nervous system in its totality, in the skin, at the spinal cord, and then in the brain. And in the brain, that's where they found it. This is going to sound scary. It's not scary at all. What they found was, for patients who had multiple pain conditions, their brain was like in a constant state of fight or flight, 24 hours a day, 7 days a week. Their brain was behaving as if their life was under threat. These patients also have anxiety disorder. I'm in this group. I have anxiety disorder. I've had it since I was attacked when I was 4 years old. Usually it's controlled. Sometimes it's not. I will confess that I was a bit on the anxious side this morning. Woke up anxious. It happens. And so we have to make sure that we've got a really good set of personal skills to recognize when the anxiety is kicking in, so we stop it, because anxiety is always going to magnify pain. It is always going to make pain that much worse. And that's what we have to stop. We have got to bring the anxiety down. Now, the constant theme in my office is, for 80% of the people who go on to develop widespread pain, there is a major physical injury. It takes 10 days of pain to put the brain into a constant state of fight or flight. God knows, to everybody here, if you're a pain patient, you've been in pain longer than 10 days. Most patients do get very anxious when they're facing a painful condition and they don't know what's wrong with them. For the other 20%, it's growing up with abuse or bullying. And I have shared my story many times. I grew up in a neighborhood with a kid my age who became a rapist and murderer, and I was one of his favorite targets. I did not leave my home without fear for a decade. And ironically, when I went to walk at the lake 2 days ago, I found another one of my old schoolmates who also was a victim, and it's a guy. And we sat there for an hour and we talked about it. And I said to him, you're the only person that knows what I went through, because you went through it too. And he was actually shot by the guy, So, childhood trauma has to be addressed. You can't live in it. And I'm not saying that right. I want to say this a different way. My health conditions began after I was attacked. Okay. And I had stomach upset. Then I was peeing all the time. Then I got vulvodynia in junior high, or high school, IBS in college, et cetera, et cetera. And there we go. Anxiety disorder, all that sort of stuff. And of course, when you're the patient, you're just so baffled. It's like, you don't understand why your life is the way it is. I was watching my friends getting married and having babies while I was laying on the damn bathroom floor every morning in pain for years. In my 20s. And the only reason I got through grad school was it was at night, because the mornings were the worst. And now that all this research has come out, literally in the last 5-6 years, and now that I understand it, I can now see the damage that was and the chaos that childhood trauma caused in my life. Because, and I said to him, his name is Tony, I said, every major decision I made was affected by anxiety and fear. Every single decision I made my entire life, my brain remembered trauma. My brain remembered fear. My brain said, don't do it, stay home. And not my fault. I did nothing wrong. I absolutely carry no shame or blame about that. And I said that to him. He said, you're right. I don't either. We were hurt by somebody who was severely mentally ill. But I grieve for that now a bit more. I do. And it's kind of like a sea of not regret. Well, it's not regret like I did something wrong. It's just, okay, now I understand it, but God damn it, why did it have to happen in the first place? And then you think about the millions of other people who have grown up in the homes of alcoholics where they were abused and how that affects their lives. You know, it's really true. Everybody has a story. Everybody has a story, and we can't see their story with them walking down the room. We can't see the story of the guy who's yelling all the time, angry. You can darn well bet something happened to make him angry. We can't see the story of that girl crying in the corner who won't come out and socialize. We can darn well now understand that that girl went through some stuff. So it's created a lot more I consider myself very empathic and compassionate, but woo, it's so much bigger than I ever thought it was. Hey, I need to go to the bathroom. Quick bio break. Here's a challenge. I want you to count by seconds how quick it is for you to start your stream. Okay? So give me 30 seconds. I'll be right back. I want to see how my pelvic floor is. Hold on. Okay. Well, now, it took me 5 seconds to start urination. That long for me. Normally it's 2 seconds. That was 5 going on 6 seconds for me to relax enough to release urine. That tells me my muscles are getting tight. I have had, I'm working really hard on trying to stop the vibration in my left, by my left sit bone. So I've been doing a lot of work there, and it's gotten better, but it's probably why my muscles are tight right now. Jane said, I always wondered why I flared every month around ovulation before menopause. I'm pelvic floor driven. What's the connection? It's the increase in estrogen increases your pain sensitivity. It's very, very common. Username says, when I wake up and hold my pee too long, it can take me up to 30, 40 minutes to start a urine stream, and it is so painful. Dude, have you had a pelvic floor assessment? Man, 30, 40 seconds? No. You need a proper pelvic floor assessment. We need to understand what's going on with your muscles there, because at least in my office, when I work with guys, and I'm not lying here, 95% of the guys I work with, we find a history of pelvic trauma and symptoms of pelvic floor dysfunction and pelvic floor injury. Again, the guy last week who was a football player and a softball player, and he did heavy weightlifting afterwards. He weightlifted for years. He's had every joint replaced. He's had both shoulders replaced, both hip replaced, I think hips twice, knees replaced, and severe pelvic floor dysfunction. Yet he'd had the surgery to work on the bones, but he'd never done any work on the muscles. And he said to me, yeah, they suggested it to me. I just didn't understand why it was so important. And believe me, he thanked me and went, okay, now I get it. And I was like, get your ass back to pelvic floor. Sorry for swearing, but it is what it is. This is the real me. Back 30 years ago when I started the IC Network, I was very academic and proper. Listen, I'm not as proper anymore. It's just street level IC talk. We're peeing and pooping. We're not urinating and defecating. And the occasional expletive comes out, and that's okay. Linda said, my grandma, my dad, me, my brother, my daughter, all have painful bladders. Linda, that's very, very interesting. I would love to talk with you about that this week. We should talk. I don't want to talk about it here because it's going to get too personal. But that's really, really important. Do genetics matter? Yes, they do. Generations matter also. My question that I would want to know is, do you all have anxiety disorder? Linda said, I have severe retinal damage, 19 years on Elmeron. Yes, I worked with several patients this week who all have severe retinal damage, and it's ugly. It's getting uglier. One of the patients that I was working with said, and she sent me the info, but I haven't read it yet because she sent it to me yesterday. Hold on. Okay, so she sent me a couple. I'm going to have to read these articles. Elmeron's disturbing history, drug that stole sight still on the shelves. Love seeing that. Apparently, there's like a hard deadline now that if you're gonna file, like this is going to be the last year you can file if you're going to join the lawsuits because you're going blind. And believe me, I support you doing that because there's going to be a lot of eye tests in the future that are going to be very, very expensive for you. But more importantly, if your eyesight progresses to the point that you're legally blind, you're not going to be able to drive. I've got patients now that I'm working with who cannot read. They cannot see their face in the mirror, and they need home health. And that's very expensive. This is a pigmentary maculopathy. It is associated with Elmeron use, The research behind that now is very, very clear. We have many, many studies now on it, that it is linked to blindness, and now it is linked to inflammatory bowel disease, and it's shenanigans going on. I suspect there are a few shenanigans going on. So it's very, very important that you join those lawsuits as quickly as you can, because you also have the statute of limitations. Right now, according to the PACER database, they paid out $38 million to patients that were given the medication. And there's probably going to be more. So this is real. And if you got a doctor who's prescribing Elmeron and they say, well, we don't see that in our office, we don't believe that's real, well, I'm going to call bullshit on that. Number one, you don't do eye exams in a bladder office. How would you even know? How would you even know unless you ask? So do you even ask? Probably not. Don't even get me started. Kayleen says, I'm miserable, no bowel movement in about a week, and literally everything hurts, even all the way up to my shoulders. You've done 4 doses of Miralax and Senna every day for the past 4 days. Girl, you got to get yourself to the ER. You got to go to the ER, honey. I mean, if you have not had a bowel movement in a week, you need to see a doctor quick. Especially with the amount of pain level that you have and the fact that you've taken the Miralax. You have to understand, too, that if you take too much, you end up with a stool so liquidy that it can't move. Because normally the way the bowel move works is through peristalsis. It pushes stool down the tube, but it has to have something to push against. If you only have water in your bowel, there's no way for the bowel to contract to move it along. That's why we have to have fiber. We have to have structure in our bowel movements, because that's something to push against, to push along. So I would want to really make sure that maybe you haven't over-medicated a little bit. I don't know, honey. I'm really sorry that you're going through that. And I think it's very, very important that you call your doctor quickly and let them know this is going on. Anne says, try magnesium citrate. Yeah. Cindy said, after 5 years, my retina damage from Elmeron is stable. My retinal specialist was very happy, and me too. Excellent. I'm so happy. I'm really happy for you. Anne says, my flares always happen in November. So think about what's happening in November. Number one, that's when it gets quite cold. And so changes in temperature stress your nervous system. So that could be a stress-induced flare. But also that's when we're going to start seeing a lot of mold. We're going to see a lot of rain. We're going to see a lot of mold starting to grow, and all that sort of stuff. So it could be environmental too. Marissa says, any doctor recommendations? We have a list of doctors over on our website. Just go to icnetwork.org. Laura says, I have IC with Hunner's ulcers. I previously had 3 cystos with hydrodistension. Currently having issues again. I'm going to ask the doctor if I can have another one. Seems to be the only way that helps. I do have fibromyalgia as well. So Laura, number one, I'm really sorry that you're feeling that uncomfortable. Hunner's lesions are considered the most severe form of IC. These are wounds in the bladder wall that are basically open. So urine gets into the wound and creates chaos in that tissue, creates a lot profound irritation and inflammation of the tissue. As I said earlier, I don't know if you were here when we were talking about the underlying causes of Hunner's lesions. We have now linked Hunner's lesions to viral infections, to neuroinflammation, and to potentially an autoimmune group. So that's good. We've got a lot of good things happening. Having laser therapy is one of 2 therapies that are primarily recommended for Hunner's lesion. The other is an injection of a steroid into the center of the lesion. Let me show you guys pictures. Hold on a sec. I mean, lesions are, here you go. I have lots and lots of pictures. Okay, so a lesion is characterized usually by what we call a coagulum, a center red spot. So let's look at this one here for a moment. And just so you know, YouTube, you're getting it real time. Facebook, you're on like a 3-second delay. So if you look, this is a perfect example of a coagulum. These center red spots. There's another one right there. And then generally what you see are red areas extending away from the coagulum. They call it a stellate appearance. It's like stars. All right, so these are classic Hunner's lesions with coagulum, stellate appearance, and neovascularity, or classic Hunner's lesions without a coagulum, but with a neovascularity. So that's these lower ones right here. Okay, so either we have a red center or we don't have a red center. So what they would do is they would inject a steroid into the center of the lesion. Let me show you some more. Okay, these are Hunner's lesions from 16 different patients. And I need to print this out again. This piece of paper is a little bit beat up. So you can see that the red areas can become quite large. That inflammation becomes quite large. I mean, obviously, this is going to hurt. There's no doubt that's going to hurt. And then up above, the inflamed Hunner's lesions. So these top 6 ones are very, very inflamed Hunner's lesions. These bottom ones are lesions that are not inflamed, that have been treated or healed. So, Laura, you can ask about doing a steroid injection. Also, the advantage of the steroid injections is that they do not leave scar tissue. Cauterization leaves scar tissue. Steroid injections don't. And you don't want too much scar tissue because then it's hard for your bladder to expand and hold urine. But you should also consider lactoferrin. I would throw in some lactoferrin in there because, again, we had that research study last year that showed that red inflamed bladders became pink and healthy and Hunner's lesions virtually disappeared. Lactoferrin is an over-the-counter product. It's derived from cow's milk. It's a protein that our body has. It's a protein our body makes. It's in our tears. It's in our vaginal fluid. It is a front line of defense for our immune system. It is also the major ingredient in colostrum, mother's milk, because it's building the baby's immune system. So we need lactoferrin in the human body to be healthy. The challenge is apparently as we get older, our lactoferrin levels drop. So they have been studying using cow lactoferrin in adult medical conditions. And a research team in Italy did one first with recurring UTI. This was 4 years ago. They were able to show that if you supplement this patient with lactoferrin to boost their immune system, their body was better at fighting off infections. Then they also did an IC study that was released last year. And what made that IC study particularly important is that they did cystoscopies and they looked at the bladder before and after treatment and they mapped the Hunner's lesions out. They knew where they were. And then they measured systemic inflammation with blood testing. And everything got better. Red inflamed bladders became pink and healthy. Hunner's lesions virtually disappeared and systemic inflammation improved dramatically, significantly. So it is it is not a man-made chemical. It comes from cow's milk. It is considered quite safe for the vast majority of patients out there. If you go over to the IC Network website, there's a big blog on it with a link to all the research studies so that you can look that yourself. Let me just show you a couple of other pictures just for kicks and giggles. You want to see a bladder stone? Remember I was talking about how these stones have rough, jagged edges? There you go. There's a bladder stone. Now, a bladder stone is different than a kidney stone. A bladder stone grows directly out of the bladder wall, usually after a catastrophic injury. And this is a picture that was sent to me by a patient that I've known for many, many years. Totally long story. Anyway, he had major surgery on his bladder, and along the suture line, he grew bladder stones because major injuries interfere with calcium metabolism, and it takes time for it to come back. So the bladder's got to get rid of the calcium somehow, and so it just grows stones. But it did stop eventually. But having these are not fun. And then if you want to see, if you look at this, see what looks like clear spaghetti in the middle of this picture? That is cancer. That is a bladder tumor. Because remember, cancer is when cells grow out of control. So, you know, you would think cancer is black and awful like a melanoma. Well, no, this can be cancer too. So if you were a smoker, if you're smoking, for God's sake, stop, because that's the #1 cause of bladder cancer. And then this is what we used to think IC was. These are called glomulations, petechial hemorrhages or glomulations, little red spots on the bladder. These are thrown out as being diagnostic of IC, that we think that this is what happens when you hydrodistend the bladder. So these have been thrown out in our most recent guidelines as being meaningful for IC diagnoses. All right. So let me go back here. Lots of comments here. Username said, I tried pelvic floor PT. It only takes 34 minutes when my lesions return. After fulguration, I can pee normally. Huh? I don't understand what you're saying there, honey. There's no way that physical therapy is going to make a lesion return. What physical therapy is going to do is touch nerves and touch muscles that have the potential of creating more discomfort. And if that's what's happening, that like slam dunk proof you have a problem with your muscles. So when you went to physical therapy, what did they find? They did a pelvic floor assessment. What did they find? Tight muscles or healthy muscles? If they found tight muscles, got to work on that. You can't leave them there because you're going to be stuck in ischemia, and that's not good. Jane said, yep, weightlifting triggered my pain many times. Form is critical, definitely. C. Sterling says, after my fulguration surgery, I feel like I'm in heaven. Doctor said you can't do the surgery too often due to the link between anesthesia and dementia. That is true. Do you have to be put under for this procedure that you're, you know, they could do a spinal. I don't know if a spinal is associated with dementia as much as anesthesia is. You know, you're making me think here. And C. Sterling said the bladder stone. Oh, listen, let me tell you, he was in agony from those bladder. He had a lot of them. You know, it's funny. Like this whole getting old business is very weird. I'm just baffled by getting old because I feel 25 and yet I have the physical age of 65. And the last 2 years and the last year in particular has been like I'm I'm forgetting more. It's like I walk into a room and I forget why I walked into the room. I mean, I can do all the scientific stuff just fine, but man, every now and then it's like, why did I walk in here? And I have to wonder about the anesthesia now that, I had that surgery, a double mastectomy a year and a half ago. I had 2 surgeries in 1 year. I wonder if that played a role in my mental funkiness right now. Or it's just that I'm getting older and I have to accept it. Everybody I talk to says it's normal. It's just freaky. I find it very, very freaky. So do you have to be put on, under for hydrodistension? Yeah, you would be put under, but not for a long period of time. It would be very, very short. Can they do a steroid shot? I was working with a patient last week or 2 weeks ago. They did it without anesthesia. It was pretty rough. What about a spinal? I mean, I guess you could just ask about a spinal. But again, that's where, I mean, you've tried the lactoferrin, but maybe give it another couple months. Just out of curiosity. I mean, if there's a chance it'll help, I think it's worth it because it's a lot less risky. Kayleen said it was 5 seconds for her to start urination. Linda said, how do I get in touch with you about the family connection? I know we talked decades ago. We have an 800 number. It's right at the top of our website. I just put it in there again. And my phones are first come, first serve. If anybody wants a scheduled time, you have to sign up for coaching. If you just have a random question and just call. And if I don't answer, or what I'm doing is when I'm working with another patient, I will message you back saying, can I call you later? So understand that, I mean, our phones are very, very busy all day, every day. So you just have to be patient. I will do the best I can. But if you absolutely want a firm time where you want to talk, you have to sign up for coaching. Bonnie says, can IC be inherited? Okay. Can a viral infection that causing a Hunner's lesion be inherited? Yes, because a mother can give it to their child. Can a injured ligament be inherited? No, unless it's a birth defect of some type. Can pelvic floor dysfunction be inherited? No, unless it's a birth dysfunction. I mean, unless it's a birth defect, maybe. I mean, I've worked with a couple of patients who have had funky birth defects down there. Oh, what's the name? Talk about memory issues. Normally, I'm really good. Okay, there was a researcher at the University of Maryland. His name was Jack. I forget his last name. He studied genetics. And there was a little window of genetics. I think that it might relate to, I think the biggest chance of any inheritance is nerve sensitivity. So one of the things we saw years and years ago was that there seemed to be a higher incidence of quote unquote IC in Northern Europeans. What would that be about? Well, I mean, I'm Norwegian. I qualify for Norwegian citizenship if I wanted it. I've always been incredibly sensitive because I'm a redhead. Redheads are born with more nerves. We have like 30% more nerves than people without red hair. That causes a lot of sensitivity. So that's one thing that could be inherited. But the other thing that we really look at too is generational family trauma, especially growing up in the home of an alcoholic where there's alcohol in multiple generations. Thus, there's trauma to children in multiple generations. That would be something we would see too. So not gene-based, but definitely family-based. Kayleen said, I'm eating very little, yet drinking loads of water. My bladder, my sciatica is so mad at me right now. Well, you got to do your muscle relaxation for that sciatica, honey. Bonnie said, whenever I eat dairy, I go into a flare. No ice cream, my favorite. You know, so Bonnie, that actually points to potentially a fungal infection. You know, a candida infection. I did the Fukushima protocol for IC 25 years ago. That's when we were all put on high dose antibiotics for a long period of time. And I ended up developing the super drug resistant Candida labrata infection that I had for 2 years. Let me tell you, fungal infections in the bladder are agonizing. And it was in my bladder. And whenever I ate ice cream, it flared like a beast because Candida grow with sugar and they love milk sugar. So I wonder. It's interesting. C. Sterling said, do you have to be put under for the steroid injection? Normally, yes. But again, I did talk with a patient like literally in the last week or two who had it done in the doctor's office in a cysto, and it was very, very painful. And she was quite traumatized by it. So I think that's a question you've got to ask your doctor. Generally, injecting things into the bladder, and I'm not talking about a bladder installation, I mean penetrating the bladder wall with a needle, that's going to be, and especially, you know, if they're doing multiple shots at one time, like Botox, that you would always do that under anesthesia. Nicola said, how do you cure a fungal infection? Number one, you stop feeding it. So we are going to be much more prone. So let me take a step back here. It was our own National Institutes of Health MAP Research Network. This was the best IC research team in the history of the United States. They did it for 15 years. They just literally ended, although they're still publishing some data. So they had urine samples over time from lots and lots of patients. And they're the ones who found fungal infections in IC patients. So this isn't some random company or alternative company selling Candida stuff. No, this is our own national government-funded IC research that found fungus in IC patients. And the more fungus you had, the higher your pain was. So that's a firm, clear, validated research study. IC patients can have fungal infections. I had a severe fungal infection. And of course, the challenge right now is a lot of fungal infections are now getting very drug resistant. Okay. So the question, the next challenge is, why are we prone to fungus? Well, because we've all been over-medicated with antibiotics, 100%. There isn't an IC patient out there who's not been on at least one antibiotic, just in case it was infection. And for most of us, it wasn't just one course of antibiotics, it was many courses of antibiotics over time, which then, of course, damages the biome, kills the good bacteria that normally eat the fungus. So now the fungus grows. And that's why it's so important that you do your probiotics and your prebiotics when you're taking antibiotics, because we got to get the good bacteria in there. Because in the end, your bladder is an ecosystem, and there's good bacteria and bad bacteria, and they fight for space, and they fight for food. And normally in a healthy body, the good bacteria puts the bad bacteria in check. The bad bacteria can't grow because there's so many good bacteria. But if you kill the good bacteria, woo, the bad bacteria come right back. And now they have control. And now they're eating all the food. And now the good bacteria doesn't have enough food to grow. Okay, so in the end, our body is a biological war happening. And we have to do everything we can to give our body the nutrients it needs to support a good immune system and to support good good things and bad things. I mean, good bacteria. Okay, so when the bad bacteria are dominant, and when the fungus is dominant, you have to understand that they need food for energy. And the very first thing we can do with a fungal infection is fungal infections need sugar. They need carbs. The more carbs you eat, the more they grow. And think about, if you ever make yeast bread, what do? You season the yeast. You pour the yeast in a cup of warm water, put some sugar in there, and you watch it bubble. Okay, that's exactly what happens in your body if you got a fungal infection and you eat sugar. Your body's a warm, safe place with a lot of sugar. Fungus can grow and prosper and grow anywhere and become systemic, and it is considered a major public health threat, and it kills people. Systemic fungal infection. So there's a fabulous book called The Yeast Connection, and also another book called The Yeast Connection in Women. That's a book that I used, and that's what taught me that a cup of pasta was the equivalent of eating like 3 Snickers bars. And it really makes you look at, helps you identify the foods that might be feeding that fungus. And for the most part, I stopped the ice cream, but I would have it every now and then. And man, every single time I had the ice cream, the fungal infection grew again. Every single time. So that's the most natural thing you can do, is lose the sugar. And of course, now we know that sugar causes cancer to grow, and I'm a cancer patient too. And so it's like, okay, I do not eat candy. I think I had 1 piece of candy over the entire Christmas holiday. Just trying to protect everything at this point in time. And if the infection is really aggressive and now it's damaging tissue, that's when they're going to put you on an antifungal, like diflucan. In the early days, 1 or 2 diflucans was enough to kill the fungal infection, but now there are some funguses that are very drug resistant, and sometimes you have to do diflucan for longer periods of time. So I did near toxic levels of diflucan, 450 milligrams a day for 7 days. I did that 3 or 4 times over 2 years. And that's what got it under control. But they had to monitor my liver very carefully because those were toxic levels of diflucan. I mean, there was no doubt I had the infection. We all saw it. I mean, we saw it. And then last but not least, the other thing that happened to me that I thought was really interesting is that, so here I took all this diflucan, right? And I'm like, man, it's good. And yet I would still get infections. And I'm like, how is that possible? It doesn't make sense. And I would go to urgent care and I would go to my gynecologist. I was the Candida experiment at my Kaiser Permanente for years. I saw every gynecologist in there urgently because this infection was running rampant. And I had a female doctor yell at me. She was very aggressive. She said, "Why are you here?" And I'm like, "Because my crotch is on fire." And she goes, "Impossible. You're on diflucan." And I had already been down this road. I'd already been there many times. And I said, "Prove it. Do a swab." She was very rough. She did a swab. She was very, very rough and aggressive. She took it, went out, looked at it under a microscope, came back and apologized. And she said, "Oh my God, I can't believe it. You actually have a lot of fungus." I'm like, "I know. That's why I'm here. I don't want to be here. I'm in a lot of pain. That's why I'm here." And she apologized profusely. And there you go. So what we found for me is that every time I did the diflucan, we killed the fungus inside my body. What I did not know is that there was a really big colony living on my vulva that was seeding it over and over again. I couldn't see it, but I had a really bad flare. I actually thought I had a kidney stone. I go to urgent care and they do the ultrasound, nothing there. And then they did an exam and the doctor gasped. He gasped when he looked at my vulva. He said, "Oh my God, I can see it burrowed into your skin." And that was the first. Nobody had ever said that to me. He said, "I can see the yeast burrowed into your vulva." And then he said, "Aren't you using the yeast cream we gave you?" And my answer was no. I thought the diflucan would kill it off. And he said, "No, there's not enough blood supply in the vulva at the skin level to bring enough of the medication to kill it on the skin. That's why we always give you a nystatin cream or a cream to use to kill any candida on the skin." And that was the last step for me. Once we killed this colony down there, it stopped. Now, I took antibiotics. I've had 2 confirmed yeast infections. No, I'm not going to say confirmed. I've had 2 yeast infections this year, both after I used antibiotics, including in December. And I was very happy that not Monostat, but it was another over-the-counter that started with a C, clotrimazole, actually killed it. So, it's an adventure out there. It's just an adventure out there, my friend. So I'm here as long as you have questions. We've been going about 2 hours now. So what am I working on right now? I am finishing up the Winter IC Optimist, our patient magazine. That's where we do, I think, our best work. So that's something that our members get. Also, our diet guide, our new IC 101 diet guide is officially for sale in the IC Network shop. We got our first copies of this new book. So this is a massive expansion of the discussion of the IC diet. I hadn't done this in 10 years. And so in this new book, it's 80 pages long. I've been told people don't want to read a lot. You got to shorten everything. That's why it's only 80 pages long. We talk about the IC food list. What can we eat? What can we drink when diets conflict? How to deal with fear of eating, diet struggles and success stories, how to work your way back to coffee, classic meal suggestions, bladder-friendly spices, foods by culture, how to approach eating out, and then, of course, wine, beer, and spirits. So this is available right now in the IC Network shop. And then, of course, this is the sister book to our flare guide. And we will have another guide later this year that's our pain guide. But before I do that, I have to write our magazine, and I'm writing a new book on ketamine cystitis and chemocystitis. And I have to re-edit IC 101. Oh, dear God. Lots of projects happening. Betty said, you discontinued hydroxyzine. Well, what supplement should I replace it with? Any of the supplements that contain quercetin, because quercetin has the antihistaminic effect. If you are also a bladder wall estrogen atrophy patient, I would suggest trying Bladder Rest or Bladder Builder. Those are the first 2 that we go to. Bladder Builder is, in my opinion, the best supplement out there, because it's got chondroitin for the bladder wall, quercetin for the antihistaminic effect, beneficial probiotics for the gut, and PEA to calm nerves down and reduce pain. So that has the best reviews of all the supplements we've ever sold. That has definitely the best reviews. If you were just a widespread pain patient with no bladder-centric issues, it would be PEA, the PEA 500. Linda said, interesting that I actually had allergy injections to teach my body to quit reacting to even normal yeast in my body. Good point. Very, very good point. Johanna says, I take amitriptyline, but I want to stop taking it. What would be a good replacement? PEA. Amitriptyline, the mechanism of action of amitriptyline in the typical IC patient is actually to calm nerves down. Obviously, it's a low-dose antidepressant. I mean, it's an antidepressant usually used in low doses, so it's certainly good for dealing with any depression. But in the typical IC patient, it's used to calm the nerves down. And so if you want to get off of that, and it's good to get off of that because it is an anticholinergic medication that is linked to dementia and cognitive decline over time. But you have to work with your doctor about that. You really have to work closely with your doctor to make sure that you're doing it the right way. I mean, listen, I can never tell you to stop anything. It's never my place to interfere with a doctor telling you to do something, ever. If your doctor wants you on this med, you got to ask why. You got to have a really good discussion with them about pros and cons. Amitriptyline is definitely, I think, one of the harder medications for patients to tolerate because it comes with a lot of side effects: dry mouth, dry eyes, irregular heart rate, and it's linked to dementia and cognitive decline because it's an anticholinergic. So if you're over the age of 60, usually they don't want to go there because they want to preserve your cognition. And so PEA, the PEA 500 or the PELIEF, PEALIEF, but the PEA 500 in the IC Network shop would be the over-the-counter version that could have the same effect, but you won't know until you try it. There's a lot of good research with it, though. Of all the supplements out there, PEA is really the game changer. When that study was done in IC in 2019, it showed that 87% of patients reported a significant progressive reduction in pain over time. It's what I take because I'm a widespread pain patient and I'm very, very focused on calming my nervous system down. My bladder is healthy. I don't need to do a bladder health supplement. I do a nerve supplement. Anne says, what supplement mimics hydroxyzine? Quercetin. You got to be careful with quercetin, though, because a lot of the cheap quercetin on the market comes from citrus, called citrus bioflavonoids. Instead, you want quercetin derived from the Sephora plant. It is not as acidic. Nicola said, I agree 100% with you over the antibiotics. Was that book Yeast in Women? I've been diagnosed with IC, had nail toe infection since 97, can't get on top of them, worried to try fungal tablets because of leaky gut. What was the tablets you mentioned after quercetin? Okay. Did I mention a tablet after quercetin? Oh, well, it's just going to be Bladder Builder, Bladder Rest, Cystomend, and Cystoprotect. All have quercetin in them and were developed for bladder-centric patients. Yeah. I don't know about the toe infections. You know, there's a lot of, I use, I'll tell you, my dad had terrible nail fungus, but he always wore slippers with the wool in them, and that creates a nice warm environment for that to grow. I use the antifungal nail polish when I do my toes because I've got one big toe every now and then dives into that. Oh, just the things that happen. It's just crazy. All right, where did my... Here we go. there anything else happening? No, I don't know of anything else happening this spring for IC. Our IC research, for the most part, is shut down now here in the United States. So if anything should be happening, it's y'all should be lobbying your senators and your congressmen to support women's research, since most of it's been studied under women's research. We need our research, that's for sure. All right. All right, so we have been going exactly for 2 hours. I think y'all have dried up your questions. So let me do this. Let's do, if there's anything you guys want me to do, I'm here. I am happy to do it. If you're missing something, you're not quite understanding it, I am more than happy to try to help you understand it. But if we're done, that's okay. We're done. I will go eat some food and watch Landman. I am in love with Billy Bob Thornton and Landman. That's my reward for doing meetings on Sundays. I will tell you that tomorrow is a holiday and I will be off tomorrow. I will not be answering the phone tomorrow because I have a friend who has a birthday. So I'm going to go be with her because she helped me with my breast cancer, and she's a breast cancer patient. So I'm going to go hang out with her tomorrow if I can get there. All right. So last call for questions. Any other questions? Well, I think we're done. So I'm going to say goodbye to YouTube. I'll see you guys later. See you next week. Knock on wood. Knock on wood. Because life is an adventure these days.